All right. Good morning, everyone. This is Jason Burnham from WashU. Happy to be here talking to everyone today. I will say that I am doing this broadcast from home because my 2-year-old has a fever. So if you hear a little kid talking in the background, that's him. Um, let's see. Okay, so today's talk is going to be about multi-drug resistant organisms. And I've tried to incorporate, you may remember some folks called in or surveyed about what things they wanted to see in this webinar. So hopefully I've covered everyone's desires for this. All right, the disclosure is that these series of webinars are sponsored by the Missouri Department of Health and the CDC Prevention Grant. So this is a little background of what we're going to be talking about today. Just a little bit of background on MDROs, and then we'll sort of walk through MDROs from start to finish. I call it identifying them, selecting their therapy, talk a little bit about stewardship, new antibiotics, ID consults, and preventing transmission, and then we'll wrap up. So anytime we're talking about drug-resistant organisms, one of the things that's helpful to think about is the resistance mechanisms, and these sort of fall into 4 different categories. So blocking entry and efflux pumps sort of go together. Antibiotics may not be able to pass through the cell wall, or if they do get in, they may hit these efflux pumps and get pumped right back out. Altered binding sites, you can think about fluoroquinolones for this. So normally the fluoroquinolones bind to a particular site, and the bacteria may alter that site so that it's no longer effective. Enzymatic deactivation is something we're thinking about for like carbapentamases or penicillinases. There's an enzyme that breaks down the antibiotic once it gets into the cell. Talking a little bit more about some of these particular mechanisms, you think about chromosomal and plasmid-based resistance genes, chromosomal being things like AMP-C that you see in these organisms listed here, Enterobacter, Citrobacter, Serratia, etc., sort of the space or escape organisms. Plasmids, these resistance mechanisms, you can think of things like NDM, KPCs, OXA48, etc. Wanted to go into a little bit more detail about some of these resistance patterns, just so if folks have laboratories that can't necessarily do detailed genetic testing, you may be able to recognize it just based on some of the susceptibility patterns. So ESBLs, or extended spectrum beta-lactamases, can be chromosomal or mobile genetic elements. And what I really want you to focus on is at the bottom of the slide here, the resistance patterns. The red ones being the resistant. The first, second, and third generation cephalosporins are resistant for ESBLs. Cefamycins, that being cefoxitin and cefotetan, test susceptible in vitro. And then things like 4th generation cephalosporins like cefepime and aztreonam are variably resistant, and carbapenems tend to be susceptible. AMP-C, like I mentioned a little bit earlier, seen on the chromosomes of space organisms, and you can see at the bottom here, high-level AMP-C production results in first, second, and third generation cephalosporin resistance, similar to ESBLs, but also tests resistant to cefamycins in vitro. 4th generation cephalosporins don't tend to have resistance to AMP-C, and aztreonam tends to be resistant. So just to review the comparison between these two a little bit. So ESBL tends to be on a plasmid, AMP-C chromosomal, beta-lactamase inhibitors, ESBL is inhibited by beta-lactamase inhibitors versus not with AMP-C. Cefamycins test susceptible to ESBL, but test resistant for AMP-C. And again, this is in vitro. It's not necessarily something you should be using for treatment, but just sort of recognizing the pattern when you get the report from the microlab. ESBL can confer resistance to cefepime, but it doesn't tend to for AMP-C. And just sort of to put it all into one chart here, the same thing that we talked about, really the bottom 2 lines are the most important here. Showing cefamycins testing susceptible for ESBL, and the beta-lactamase inhibitors testing susceptible for ESBL, but not for AMC. I did want to mention, even though we talked about ESBL testing sensitive to beta-lactamase inhibitors, there's this recent trial last year, the Marino trial, looking at ceftriaxone-resistant E. coli and Klebsiella pneumoniae. And it basically showed that piperacillin tazobactam for patients with this resistance profile was inferior to meropenem. So it's pretty new data, but I think it's important to remember when we're making treatment decisions. Moving on to the Klebsiella pneumoniae carbapenemases, or KPC. These can be found in any of the Enterobacteriaceae, and you can see the chart is getting even more red here. So cefamycins are testing variable as well as the cefepime. And I apologize for the screen sort of changing on and off here. I'm moving around the webinar controls. But first, second, and third generation cephalosporins are all going to be resistant, as Trianam. And that's something important to remember when we start to talk about metallo-beta-lactamases like NDM1. So pretty much everything resistant here, but you can see the susceptibility to Trianam. Sorry for the child sneezes in the background there. Drug-resistant infections are on the rise. You can see here on the left, 2001, only one state reporting, and as of 2013, almost all the states are reporting CRE to the CDC. And this is 6-year-old data by now, but it's the most updated graph that they had. In addition to being common, they are costly. So drug-resistant infections cost estimated as of 2014, $2.2 billion excess cost each year. And in addition to being common and costly, they're also deadly. This is a slide showing the timing of appropriate antimicrobials. So this is particularly for patients with hypotension, i.e. septic shock. So the longer you wait for appropriate therapy, the higher the chance the patients have of dying. This is sort of led to some additional studies and some additional problems, because we're always concerned about getting that the antibiotic right up front. We actually did some work here at WashU that showed in a cohort of patients who had drug-resistant Enterobacteriaceae infections, as long as they got antibiotics that were appropriate up front, they did no worse than people who did not have drug-resistant infections. So it doesn't seem like it's more virulence from the drug-resistant infections. It's just about getting the right antibiotics. So as I alluded to, this has sort of led to some problems in terms of overuse of broad-spectrum antibiotics. These two graphs here, on the left is MRSA, on the right is Pseudomonas, and on the y-axis is the percentage of the time that people are receiving coverage for these bacteria, and on the x-axis is how often they actually have it. So you can see only 2 to 5% of the time do someone have MRSA or Pseudomonas, but between 5 and 60% are getting anti-Pseudomonal and anti-MRSA agents. So lots of folks are receiving unnecessary antibiotics, which leads into the next portion of the talk, which is thinking about how to identify patients with drug-resistant infections and then selecting the therapies for them. Predicting MDROs is a significant challenge. If we had the perfect algorithm, we wouldn't even need this talk. And there's no really one-size-fits-all algorithm to identify these folks. This slide here, I don't intend for you to take in all the details. Essentially, what this is showing is that folks can use sort of local data to predict which patients are going to have an ESBL infection with pretty good sensitivity. You can see at the bottom, there's one group that 100% of the patients who were predicted to have an ESBL did have them. And there's a variety of examples of this. This has been done for predicting cefepime resistance, for predicting meropenem resistance, etc. But one of the sort of more relevant and feasible things to do, talk about on this slide, which is a study from 2017, in which essentially what the investigators did was just look back at the patient's previous culture data to see if their old culture data could predict what infection resistance patterns they had at the current admission. And you can see that if you didn't have drug resistance before, the negative predictive value, the green line here, was pretty good. So if you didn't have resistance before, you're pretty unlikely to have it during the current admission. And then for the red line, if you had, this is showing positive predictive value. So if you had drug resistance before, you're likely to have it again, and that risk sort of drops off over time. So this may be helpful and can be done fairly easily, I think, just based on what data is available for that patient at within the healthcare system that they're being admitted to or cared for in. So there is the potential for homegrown algorithms, though it does require a fair bit of data management and analysis, so may not be possible at certain sites. Having an antibiogram and looking at the patient's prior antibiotic resistance patterns is very helpful. And then I don't know what the use is throughout the folks who are listening in today, but rapid diagnostics are something that may not be the wave of the future. This slide is some data that we have on one particular type of rapid diagnostic that was used here at Barnes in a study. And essentially what I want you to take away from this is that the time to blood culture positivity and antimicrobial susceptibility results was greatly sped up by this system. So between 1 and 2 days faster than what would occur during normal microbiology processing. So another sort of rapid diagnostic or stewardship thing you can think about, this is a systematic review and meta-analysis of MRSA PCRs, if those are available at your institutions. When a MRSA PCR was negative, there was a very, very good negative predictive value, saying that very unlikely to have MRSA pneumonia, although this is fairly dependent on prevalence, and you can see the positive predictive value is not very good here. Just another word about rapid diagnostics. This slide is showing you a systematic review and meta-analysis of rapid diagnostics, and essentially the take-home point here is that they compared places that had rapid diagnostic testing and used an antimicrobial stewardship team to help interpret, analyze, and act upon the rapid diagnostics to locations that did not have an antimicrobial stewardship team to act upon those. And mortality was reduced if you had a stewardship team in combination with the rapid diagnostics, but if there was no stewardship team, essentially the rapid diagnostics weren't being acted upon and there was no difference. So you need a stewardship team to help you out with the interpretation of these tests. Which leads us into the next portion of the talk, which is looking at stewardship and drug-resistant infections, and then we'll talk about some of the newer antimicrobials that are coming out for some resistant gram-negatives. So some of this I've touched on a little bit before, but some of the key parts of stewardship include using the antibiogram. There are certainly places where there's very low incidence of MRSA, so it really doesn't make sense to use a lot of empiric vancomycin, but you really have to know your local antibiogram to determine that. And every place is going to have different formulary considerations to take into account. For example, at WashU, we don't really use a lot of ceftazidime, but we use a ton of ceftriaxone, and that's going to vary from institution to institution. National guidelines can be our friends in terms of helping us decide what is the best definitive therapy for particular types of infections or infectious syndromes. And order sets have been shown to help guide clinicians in their choice of antibiotics. So if there is a order set for pneumonia and they can select okay, this is community-acquired pneumonia, and all that's available to them is things like ceftriaxone and azithromycin. It's going to significantly reduce them from, or reduce their use of things like vancomycin and cefepime for a community-acquired pneumonia. Similarly, for C. diff, if you have an algorithm that helps them choose PO vancomycin instead of fidaxomicin, that's going to be a boon to stewardship. And then prospective audit and feedback has been shown over and over again to help reduce antibiotic utilization and in many instances antibiotic costs, just telling the clinicians and comparing them to their peers, saying here's where there is room for improvement. This slide has a lot of things that are sort of fall into the IT bucket of things. So for example, here at WashU, we have things like automatic stop dates. So when you put in an antibiotic, you can say, okay, well, I'm treating pneumonia and I want to treat for 7 days. And so you have to put in a stop date. And this prevents the thing that can happen where you just sort of forget what day is day 7. So the patient ends up on 8, 9, 10 days of antibiotics. If that's already built in, it's going to stop on its own. And it's one less thing you have to think about. Antibiotic timeouts can also be built into alerts. So for example, a patient comes in with sepsis, let's say, and they're put on vancomycin and cefepime. An antibiotic timeout after 48 hours could come up and say, hey, do you really still want to be using these? And you can reassess at that time. It's sort of a prompt for people to think about whether they truly need it. Maybe that patient ended up having influenza and no, they don't need the vancomycin and cefepime anymore. It's just one more thing to help people think about appropriateness of their therapy. Another thing that's important for stewardship is this idea of IV to PO transitions. And actually, we have a protocol where some of this is automated without clinicians having to give their input. So for example, someone who is on intravenous doxycycline but has an intact gut and is awake, alert, and has no contraindications to taking PO doxycycline, they'll automatically get switched. Other important parts of stewardship, just in terms of appropriate dosing and use of particular antibiotics, is therapeutic drug monitoring. And then as far as stewardship goes, there's certainly many ways to do stewardship and levels of integration, but stewardship rounds, whether that's walking through the ICU with the attendings or walking around the wards with the attendings as they make their decisions, perhaps it's reviewing antibiotic orders for the day, whatever the methodology is that's important to help choose antibiotics. So these sort of all fall into the IT solutions bucket, but in addition, for example, ordering can be really helpful for antibiotic use. As an example here, when we took urine cultures out of the first line order set for the emergency department, significantly reduced our rates of positive urine cultures. And another thing you can think about is, something that we call here a UA reflex. So you can't go straight to a urine culture. You start with the macro, micro, and then if those are positive, move to culture from there. So those are some more sort of IT solutions. And then as I sort of alluded to earlier, the integration of the stewardship team with rapid diagnostics, if you have them, help you help the clinicians interpret them and act upon them quickly, so that so you're getting the whole bang for your buck. So the next few slides will focus on some of the treatments for multidrug resistant gram negatives. First up, aminoglycosides. This was one of the things that people had asked to hear a little bit about. There's been a little bit of back and forth in the literature about the use of aminoglycosides, and this was a well done study last year or the year before, looking at the use of empiric aminoglycosides in sepsis. And essentially what this slide is telling us is that even in patients who receive 3 days or less of gentamicin, empirically in sepsis, they have an increased risk of renal failure, but really no reduction in time to resolution of their shock. So the take-home message here is that it's probably doing harm and doesn't seem to be doing a lot of good. So it's not something that we recommend at WashU, though it still does happen sometimes. It just doesn't seem like it's a good strategy and could actually be causing some harm. I'll spend a little bit of time on this slide here, some of the new treatments for drug-resistant gram-negatives. So ceftolozane, tazobactam, or Zerbaxa, ceftazidime, avibactam, or Avicaz, meropenem, vaborbactam, or Vabomere, and then plasmamycin or Zendry. As far as FDA indications go, they all carry an FDA indication for complicated UTIs. Zerbaxa and Avicaz both carry an indication for complicated intra-abdominal infections, though this has to be given with metronidazole because they do not have anaerobic coverage. I've listed here, the Avicaz also has the added benefit of being FDA approved for hospital-acquired and ventilator-associated bacterial pneumonia. The usual dose I've listed here, and I didn't go into the specifics of renal dose adjustment, but generally speaking, once you get less than a creatinine clearance of 50, there is some dose adjustments that need to be made for each of these drugs. As far as the coverage goes, your best Pseudomonas drug among this group is the Zerbaxa. Acinetobacter, probably the best is Vabomere, though it's probably not that much different from regular old meropenem. As far as ESBLs go, really Avicaz, Vabomere, probably are going to be your go-tos for ESBL, as well as CRE and KPC. Plasmamycin does have pretty good activity against these as well, though, as an aminoglycoside, there is the risk of renal injury. And you can see down here at the bottom, anaerobes really only covered by meropenem, and that's, Vabomere, and that's really all coming from the meropenem. There were some questions about the role of combination therapy that got brought up in a previous session. And so just wanted to say that there's a lot of debate about this. And this is a fairly recent trial that was well done comparing colistin and meropenem to colistin alone. And there's really no difference in outcomes between these groups. This group ended up being predominantly Acinetobacter, but there were other drug-resistant infections, and there was really no difference. As far as other combination therapies go, the studies that are available, there's probably a fair bit of publication bias as well. They're not very well controlled. They're all sort of, most often retrospective observational, and the sort of systematic reviews that have been tried to be done on these topics basically end up saying that there's this trial designs and the quality are so low that definitive conclusions can't be made. So generally speaking, combination therapy probably not beneficial, and if you're really getting to the point of considering these sorts of things, maybe shoot us an email. Talking a little bit about when to treat and when not to treat. This is just a little slide showing the very recently released clinical practice guidelines for asymptomatic bacteriuria treatment. Essentially, to summarize for you, there's very, very little or very, very few cases in which you should be treating asymptomatic bacteriuria, but that sort of applies to all non-sterile sites. Of course, if you have something in the blood or something from the cerebrospinal fluid, that's going to be something you need to treat. But non-sterile sites, you can grow lots of things that aren't necessarily something that need to be treated. And the other thing that you have to keep in mind is just because something is drug resistant doesn't mean it needs treatment. So a multi-drug resistant or extensively drug resistant bacteria from the urine, if the patient doesn't have any symptoms, just because it's drug resistant doesn't mean you need to be giving them AVCAS or Vabomere. As far as antibiotic resistance goes, this is sort of the battle we face, always pushing the rock up the hill, and as soon as we move out of the way, it's going to slide back down. So as soon as the new antibiotics get in use, there's reports of resistance to them. So the more we use them, the more likely the resistance is. So in that vein, I would like to talk a little bit about short versus long courses of antibiotics. The longer we go, the more likely the resistance is. So if we can shorten it, maybe we can reduce the total sort of population antibiotic resistance. These next couple of slides are just a systematic review and meta-analysis comparing short versus long course antibiotics for a variety of different types of infections. This first one is clinical efficacy, and what you can see is if you look at the bottom of the slide, the little diamond there shows that there's no difference in clinical efficacy between long and short course antibiotics. Similarly, for short-term mortality, again, the little diamond at the bottom, no difference in short-term mortality when you compare short versus long course antibiotics. And finally, the other outcome that they looked at in the study was infection recurrence. So again, same message, no difference in long versus short courses. So to talk about this in a little bit more detail about the various types of infections and the evidence, on the left here, we have the condition, in the middle column, the recommended duration, and on the right, all the supporting studies to suggest that this is a good strategy. So for community-acquired pneumonia, 3 to 5 days is sufficient, and sort of choosing between 3 and 5 depends on the patient and how they're doing, and that's true for sort of all the ranges on this slide. Hospital-acquired pneumonia, ventilator-associated pneumonia, 7 to 8 days has been shown multiple times to be as long as you need to go. For skin and soft tissue infection, cellulitis, 5 to 7 days has been shown to be sufficient. For complicated UTIs, even 5 to 7 days, and this is sort of including males as well. So something that people often think need a little bit longer treatment course. For complicated intra-abdominal infections, as little as 4 days, although this is with adequate source control, and that is a little bit nebulous sometimes, so this can be a pretty challenging one in my experience. Infective COPD exacerbations, and this is not just sort of the person who needs steroids, but someone who truly has an infection that isn't a viral infection. 3 to 5 days is sufficient. And this, there's only one study cited on the right here, but it's a really well done meta-analysis from 2008 that had tons of studies in it. And something that makes a lot of people nervous is neutropenic fever. And what has been a practice for a long time was if you have neutropenic fever and you don't have recovery of your counts, to give antibiotics until count recovery. But there's actually some emerging data suggesting that if patients are afebrile and have normal vital signs, even if they don't have their counts recovered, it may be safe to stop their antibiotics. And just one sort of final comment about this. These are obviously guides and not definitive durations. If there's an immunosuppressed person without source control for something on this list, then that sort of changes things. So we talked a little bit about the treatments and stewardship and durations. I want to talk a little bit about infectious disease consults and how to maybe prevent transmission of these pathogens. Going through this talk, we talked about how MDROs are common, they're costly, and they're deadly. So what is the role of infectious disease consults for these patients? This is some work we did at WashU, but there's data like this from other institutions as well. we studied over 4,000 patients with a variety of drug-resistant infections, and the take-home message here is really that readmissions, mortality at 30 days and at 1 year was significantly reduced if those patients had an infectious disease physician see them while they're in the hospital, and this is controlling for all their other comorbidities and such. So it seems to be a true effect. Like I said, this has been replicated at other places as well. And this again is just showing you sort of graphically that on the top here, the folks who had an infectious disease consult were much more likely to be alive at 30 days than those who did not. The next section is a couple of poll questions just about how infectious disease consults and physicians are utilized at your institution. So I'm going to give everyone just a little bit to make sure they can be ready to respond to these poll questions. And if you've forgotten that, this is where to go to log in for that. So I'll hold this up on the screen for just a second. It's the pollev.com/masssec. So
Jason, I'm going to break in here for just a second and also say, if everybody looks at their control panel, there is a little hand raise button. If you want to skip back one slide.
Oh, sure. Sorry.
So if people want to verbally ask questions, please feel free to just raise your hand and I'll unmute you so that people can ask questions verbally. We've had, good success with this in the last few webinars. So just please feel free. I'll monitor and unmute people as they come by.
All right, I'll go to the question now, Kevin, if that's okay.
Yeah, absolutely.
Okay. All right. So, like I said, these questions are just a little bit about what's going on with infectious disease consults at your hospital. So, for this one, who currently manages patients with multidrug resistant organism infections at your hospital? Is it the physician, infectious disease physicians, infectious disease pharmacists, just the primary inpatient team, whether that's medicine or surgery or neurology or whatever the service may be? Maybe you have a mix, maybe it's primary team, pharmacists, physicians, and it's mostly infectious disease, or maybe it's mostly the primary team, but a mix. So just wait for some responses here.
Hi, Jason. This is Erin Rasmuel. I just wanted to say we've got a question from Brad Nicholson showing up in our panel here. Do you want to address that now, or do you want to wait and address that at the end? I can find it.
Yeah, I can do it while we're sort of waiting for some folks to respond to the poll.
Okay. Do you want me to read it, or can you see it?
I actually cannot see it, so if you don't mind reading it too.
I don't mind at all. It says, we currently have Primaxin as the carbapenem of choice. Do you see a reason to change to Mero-Vab combination as the formulary agent of choice for carbapenems? If so, what data is there for 4-hour infusions of this product?
So if I understood the question, it was switching from Primaxin to Vabomere or switching to Meropenem?
I think the Vabomere was the question.
Oh, okay. Well, in terms of beta-lactams, just to talk about infusion times, there is some data about prolonged infusions and improved outcomes. We don't do a very good job in the U.S. of sort of monitoring levels of beta-lactams, though that is something that is done in other countries. As far as switching from Primaxin.
Primaxin is cilastatin imipenem.
Yeah.
So,
As far as switching to Vabomere, um, if you're going to be using an empiric carbapenem, uh, if you don't have high rates of sort of CREs, KPCs, ESBLs, probably I wouldn't go immediately to the Vabomere, just since it is sort of a more broad spectrum agent. But if there's someone who has known resistance to a carbapenem, but is susceptible to Vabomere, that would be a situation where I would switch. But Vabomere I wouldn't be using sort of as an empiric therapy. I hope that answers the question.
So I'm going to add, there's a couple of additional sort of nuances there. One is that Vapomere, because it is a brand name drug and very new on the market, is extraordinarily expensive. So switching over from imipenem cilastatin or meropenem alone probably doesn't make any cost efficacy sense, especially if you're not in a place with incredibly high, carbapenem resistance. And then it's got some other major issues such as stability. I believe it's got a 4-hour stability. So, especially if you're talking about a prolonged infusion, so it would be a very difficult drug to figure out, how to use in that way. So probably doesn't make much sense. And, honestly, we, and at Barnes, which is a tertiary care center that gets referrals for specifically infections like this, we rarely ever use it. So if that tells you anything.
So let's see. Kevin, as far as voting goes, I, I is it going through? I can't tell actually.
Jason, this is Mike. I actually tried to answer some of these, so we may have some problems loading the Tool Everywhere
Oh, okay.
response data.
Okay. Perhaps we could attach these to a future presentation or something if the responses aren't coming through.
Yeah, I think that makes sense.
Okay. All right. Well, we'll skip these if it sounds like we're having some technical difficulties here. All right. All right. I'll just skip these. We'll do them at
I'll
another
be watching
time.
for hands up. So if anybody has any future questions, please feel free to just raise your hands, and then I'll open up the line.
And I just have a few more slides here, and then happy to take additional questions. So talking a little bit about preventing multi-drug resistant organism infections, stewardship really does play a role here. There's plenty of evidence to show that reductions in antibiotic use reduce C. diff rates and reduce overall resistance at different institutions. Sort of appropriate use of contact isolation is also good in preventing the spread of drug-resistant infections. Of course, the 5 moments of hand hygiene that you can sort of see over here, and you're probably familiar with, before touching a patient, sort of whenever you're doing aseptic procedures, after touching a patient, with fluid exposures, and then after touching patient surroundings. The other important thing to think about is environmental cleaning, which everywhere is required to do, but it's just worth noting that drug-resistant organisms have been shown in many studies to persist on surfaces for months if not properly cleaned. Just wanted to comment a little bit because these are sort of hot topics in the field of preventing drug-resistant infections. There's this emerging field of sink and plumbing designs, a fair amount of data showing that the plumbing system and splash of hospital water may be a way for drug-resistant organisms to spread within and between patients. And then as far as screening goes, there's a fair amount of controversy, and if you got 100 hospital epidemiologists in a room, they definitely would not come to a consensus about screening, but suffice to say that MRSA screening is probably the most widely accepted of them, though it is still controversial. And then VRE and multi-drug resistant gram-negatives are more controversial. And honestly, for multi-drug resistant gram-negatives, I don't think we really know exactly how to interpret and who best to screen. So this is something down the road. As far as preventing spread of drug-resistant infections, this is a systematic review and meta-analysis looking at acquisition of gram-negative bacilli that are multi-drug resistant in intensive care units. And really what I want you to focus on is the top left, where there's all those three-letter phrases. Essentially what this this study showed is the more you do to prevent drug-resistant organisms, the less likely you are to have spread. So if you had an antimicrobial stewardship program in place, so that's ASP, if you were doing consistent environmental cleaning, if you had all the standards in place, you're much less likely than if you took away any of those individual components. So, as I said, those are sort of the end of my slides. I'll just wrap up here. So, predicting MDROs is challenging. Using locally developed algorithms, if you have them, can be helpful. Antibiograms, certainly. Looking at patients' prior drug resistance patterns from prior cultures, and then if you have them, rapid diagnostics in combination with the stewardship team. If you have availability of infectious disease folks, consulting with them has been shown to improve clinical outcomes. We talked a little bit about the new options for multi-drug resistant gram-negatives and some of the benefits and drawbacks of them, and talked a fair amount about all the things that antimicrobial stewardship programs can do to help improve clinical outcomes. But overall, the multifaceted approach is necessary to help improve patient care. So I just wanted to thank everyone on this slide who have been really helpful in all the research that we've done and putting the data together, and of course Masik for letting me give the talk. As far as upcoming events go, webinars are on Fridays at 10. We have a case conference on April 12th, and there will be another one on the 26th, still figuring out the topic there, and then in May, the AUR module. And then I think we can go for additional questions here and any other things. That's the end of my prepared slides, so I'm happy to talk and see what other questions folks have.
Thanks, Jason. I have one that just, can you talk a little bit about MDRO organism colonization? Because you showed a slide which showed, that a patient's history of MDRO infection or MDRO cultures is pretty predictive for quite some time of their risk of having a subsequent MDRO infection. I'd just like to hear what you think about in terms of where do these people get colonized? How does that present? Is it a clinical concern for patients who've had previous MDRO or highly resistant organism infection?
It's a good question. I'm not sure that we're quite there yet in terms of a definitive answer, but there have been some studies, and again, this ties in a little bit to the screening for multi-drug resistant gram-negatives. There have been a few studies in sort of cancer populations where they screen folks for particular drug-resistant organisms and saw how often, when they were neutropenic, did they develop an infection with one of those organisms, and they were more likely, if they had a colonizer that was drug resistant, to again have that colonizer as an infection, but it wasn't 100%, so I don't remember the exact number off the top of my head. but they were more likely than patients who weren't colonized with resistant gram-negatives to have a resistant pathogen. But it, I want to say it was on the order of maybe 20 to 30% who had a drug resistant. So the vast majority of them did not have a drug resistant pathogen, even if they were colonized with it. So one of the issues with screening is we don't always know who to screen. It can be very time and cost intensive, and we don't really know at this point what the sort of bottom line bang for the buck is in terms of cost effectiveness. So I think more data needs to be collected.
I think I know why we're having technical difficulties. Don't worry, we'll have that fixed for follow-up conferences. Apologies to everybody who's trying. I think we basically have a software desync. I think, and most of these are Enterobacteriaceae, so they colonize the gut. So it's a very difficult place to even know what's going on. It's not like you can do rectal swabs on everybody.
Right.
Jason, this is Mike. I've got a question. For hospitals that have limited resources, what do you think is the single best thing that they should be doing now to try to better manage multi-drug resistant organisms at their facility? In particular, if they have limited resources in terms of infectious diseases expertise.
So, I think MASIC is going to be a good resource for a lot of people. Just having someone else you can talk to who has seen these cases, who has some experience with it. I think probably in the future, one of the things that is going to be more readily available and will be a really excellent resource is something like telemedicine. So whether that's talking physician to physician or physician to pharmacist or physician to patient, the technology is out there. It just really needs to get out there and spread. But there's certainly infrastructure considerations and costs, but I think that's going to sort of be a boon to stewardship out in more remote areas that either don't have the resources to hire infectious disease physicians, or they just have a hard time getting folks to stick around. So I think that's a wave of the future.
I think you made a really good point with showing that there is because of increasing awareness, people are in some ways over treating and not really tailoring things to their patients. So the constant sort of pressure that stewardship puts on people to justify their usage of broader spectrum antibiotics is actually a great assistance to this. You've got two problems. One is the need for complex therapies with MDRO organisms, and then the need to not use those in the context of infections that can be treated with much less costly, more narrow spectrum agents. So it's a big concern, and I think stewardship programs do an enormous service to hospitals and the community at large in trying to prevent over-treatment.
Yeah, it's a big issue for sure.
So, haven't seen any hands up. Let's just double check that there are any other questions. As we've said before, anyone, if they have a question that they think of later, can always ask it on the Missouri Stewardship, mostewardship@westall.edu email. We've been having some very good conversations on there, and I think people have liked how responsive it is. At least that's our impression of it. The next conference, as we've said, is on April 12th, and that will be a case conference. And we've already got some good cases percolating, so stay tuned about that. Any last questions or thoughts from people? Not seeing anything. All right, so we'll give people back 10 minutes of their time then. Thanks everybody for attending this MASEC webinar, and stay tuned for more. And as I got the feedback survey to work, though the screen shot is not representative. So if anybody has feedback in how to make these better or more useful to use, please leave that so that we can adjust conferences in the future. Thanks, everybody.
Thank you. Thank you, Jason, for presenting.
Yeah, thanks for having me.
Hope your kid feels better.
Thank you.
All right. Thanks, everybody. We're going to sign off now. How do I... Hold on 1 second. I need to turn off the presentation. There we go.
Kevin, where are you right now? You're not in your office. Hello?
It looks like it's still recording, guys. I'm going to hit stop recording, okay?
That sounds perfect. Kevin, are you still on?